Alrighty, you never disappoint, Dr. Gautam. Great job. Next, I'm happy to present the last or introduce the last session, which is pre-exposure prophylaxis, a case-based discussion led by the amazing Raphael Landovitz. I'm going to prop you up for a second. Dr. Landovitz is an infectious disease and HIV clinician with both clinical and research interests in HIV prevention. Just to say, he's the grand poobah of long-acting agents for PrEP and leads many of the trials for NIH, and really excited to be on this panel with him today. Take it away, Raphael.
Thank you so much, Alison, and I'd like to thank all of the organizers of this conference for an opportunity to be with you all. This year, I'm going to be going through some tough cases in HIV prevention. We've updated them for this year because things just keep getting more and more complicated rather than more and more straightforward. And we have a really incredible panel here with us today, including the lovely and talented Dr. Agwu, who will be staying with us for this session, as well as Dr. Connie Celum and Dr. Monica Gandhi. So I feel like I'm here with friends. So hopefully this will be a really fun discussion. These are my disclosures. And these are the learning objectives of this session. So, anybody who has heard me talk about pre-exposure prophylaxis knows that I'm a huge fan of this method of sort of getting everybody on the same page with the efficacy data across populations that support the use of tenofovir-based pre-exposure prophylaxis. And the concept here, and I grew up in the Northeast of the U.S., and I think anyone who is from the Northeast of the U.S. or has been there over the holiday time remembers that outside, places of worship, synagogues, churches, mosques, there's often fundraising activities for various charitable causes, and they post a big thermometer outside, and they show as donations come in, they fill up that thermometer to show the progress. And so this is my conceit because, I know when anybody puts up a data slide with just efficacy results of clinical trials, I immediately check my Instagram and start sending emails. So this is my conceptualization of the efficacy results of the randomized clinical trials of TDF-based PrEP that really shows the wide variety of results that confused providers and consumers of PrEP early on. And of course, these wide disparities in clinical trial results ultimately helped us evolve to a second generation of PrEP agents that people called PrEP 2.0 that included the dapivirine ring, which is before the FDA currently for review and is approved in Europe, and as well as taft based pre-exposure prophylaxis for non-vaginal exposures. And we, of course, now understand that, if you don't take an oral PrEP agent, you can't expect it to work. And that's probably the origin of a lot of the varied clinical trial results we saw. And people are wondering why there's a red dot bouncing up there in the PROUD trial. And it's because they didn't measure drug levels. So it's estimated based on pill counts and other sources of triangulation. But anyway, I think we all can agree that PrEP, at least current PrEP that's available, can be pretty straightforward when the creatinine clearance of the person who's considering PrEP is greater than 60. There's no history of bone abnormalities. They don't have chronic active hepatitis B, and the patients are reliable, and they come in every 3 months like clockwork, right? And they don't have medical comorbidities that can complicate these things. And of course, unfortunately, or fortunately, because we're all not going to be out of jobs anytime soon, there aren't that many people who fall into this nice, easy schema of people that it's easy to deliver PrEP to. So we're going to talk about some of the complexities that go into these decision making. And let's start with the first case, if that's okay. I call it Beans, Beans, and Nothing But Beans. That's not a leading title at all. And so this is a 50-year-old man who has type 2 diabetes, chronic kidney disease stage 3, and hypertension, who recently started a relationship and I apologize, this is not people first language here, so I shouldn't have used this. This is a man who's also living with HIV and is seeking advice on how to avoid HIV infection. His partner admits with using his ART for HIV treatment regularly, but he's mostly adherent, and they don't like to use condoms. So 1 month after starting PrEP, you note that his creatinine clearance has dropped to 55. His urinalysis is normal, and you decide to recheck his safety labs, and now his creatinine clearance has dropped to 50. So the first question, and this is so fun, we've got poll questions for every one of these cases. What do you do here? And the options are you continue daily oral TDF-FTC and you recheck in 1 month. You say, hey, if this is something that you can plan around when you're going to not use a condom for sex, you can use event-based dosing. And another option might be you can just take your TDF-FTC 3 times a week. How about that? Or you could switch to taft-FTC or something else. And hopefully, if the magic of this conference works, there it is. There's a poll coming up, and hopefully everybody can vote and enter what you think is the right thing to do, and then we can talk about it. We'll give people a minute. Okay, so we have a lot of people saying switch to TAF. FTC is the most common answer here. Alison, let me jump to you right out of the box. How are you approaching these situations of people with some comorbidities that predispose to renal dysfunction? They've got tenuous renal function to start, and you have a hint that things aren't trending in the right direction. What are you doing clinically?
Yeah, so I think in that case, it's amazing. It's nice to have the option of TAF-FTC. And so I am turning to that for those where I'm concerned, where people are tenuous, et cetera, and doing that. And of course, that is for individuals who aren't born with a vagina. You can turn to that.
Yeah, it's so interesting. When we sort of look carefully at the Discover data, and we'll show those data in just a second, which was the head-to-head randomized trial of TAF-FTC versus TDF-FTC and MSM and transgender women that Gilead did, the clinical outcomes weren't different for renal dysfunction, but these very sensitive markers of glomerular filtration were more favorable for the TAF-FTC. And so I think, certainly in people living with HIV, we've seen this phenomenon of it being less renally offensive, and there's certainly a suggestion of that in the prevention literature, but I don't think we fully have an answer yet. But I tend to agree with you. It's sort of what I would do. Connie, is that what you're doing also?
Yeah, I have to say I am not in the, I guess you'd call it maybe the camp of people who routinely use FTAF for PrEP, because I think the benefit is really only relevant in terms of renal insufficiency for those who do have predisposing conditions. But with the case that you presented to us, I think he would be someone, just given his comorbidities and the fact that early on he's had a drop in his creatinine clearance to 50. You didn't tell us what it was initially, but if it was low to start with, he would be probably one of the relatively few cases where I would use FTAF instead of TDF-FTC.
Yeah, thanks, Connie. I'm also going to turn to Monica, who's sort of led us in some of these pharmacokinetic analyses of looking at frequency of dosing with TDF-FTC and effect on renal function, and figuring out who's more likely to have these drops in renal function. Monica, how are you thinking about it? Do you have a threshold? Your data sort of suggests 90 as a good place below which you'd be increasingly concerned. Is that what you're doing in clinical practice too?
Well, yeah, we did perform an analysis where we looked at doses per week of TDF-FTC and the decline in renal function in doses per week assessed objectively for pharmacokinetic measures, and the decline in renal function in just this group, someone who's 50, someone who already has renal insufficiency risk factors. And taking 4 doses a week was definitely safer than taking 7 doses a week in terms of decline. And if, essentially the IPREP, the IPREGA studies really showed that people with frequent sexual activity, which I hope is happening at the beginning of this relationship, that 4 doses a week, the IPREGA event-based dosing ended up being around 4 doses a week. So it really could be that the 2-on-1 dosing of TDF-FTC is definitely safer than the 7 days a week and as effective. I would say that you're going to talk about this, but I am waiting for I know that the EUA has been, now we use words like EUA, but I believe the putting in for approval for the Cabotegravir IM has been submitted to the FDA, and I'm eager because, to be honest, I'm worried about both TAF and TDF in someone who already has ongoing risk factors for renal insufficiency. It's only going to get worse and not better, and I really don't want to contribute with preventative agents. So I'm going to be more interested in something else for this patient when we get it.
Monica, I love that. I love a something else answer. And, audience members who have other thoughts, please do jump those in there and put those in the chat if there's something else that you would do. Just coming back to one thing that you said, Monica, about this IPREGA dosing, and cross-study comparisons always make a fool out of you and make a fool out of me, and I always say this anyway, but it was fascinating to me that in the IPREGA sub-analysis, where they looked at difference in changes in creatinine clearance in the people who got the active TDF-FTC versus the placebo, they didn't see a difference in changes in creatinine clearance, but in the daily use randomized trials, we did see that. So again, always dangerous to make those cross-study comparisons, but it does suggest to me that maybe if you're using less TDF-based PrEP, as a consequence of your use of it in a 2-on-1 context, you may be able to remove some of that renal toxicity.
That is what our study, showed in terms of averaging under the curve of under the curve of tenofovir exposure over a week, that 4 doses led to less renal insufficiency than 7.
Yeah, and one of the most common questions I think we're all getting clinically at this point is, do we have sufficient data, or is there a suggestion that you could actually use TAF-FTC in that 2-on-1 schema? And the answer is no, we don't yet. I mean, and it's data. Yeah. It's premature to do that. Is my gut that it would work? Yeah, probably, but we don't have the data to support it, and I think we need to be careful. We've been surprised, and that's why you do clinical trials of things that you think are going to work, and that the PK data sometimes say are going to work. They don't work. So I would encourage people not to use it in that way.
And then treatment is prevention, maybe talking to the partner, seeing what we can do. That's such an effective strategy, and maybe going back to treatment as prevention.
Yeah.
Maybe that partner needs a Cabotegravir rilpivirine.
Yeah, exactly. That is approved. Great point.
Yeah. And, I think we can never forget that, we keep calling it treatment as prevention, but let's not forget, as we talk about PrEP in this session, that treatment is prevention, right? Let's not forget that, right? So I think it's a great point, Monica. It wasn't going to be the focus of what I was going to talk about, but, this inconsistent use of ART by the partner is something that needs to be addressed in parallel. So great, terrific. Let me just sort of zip through the supportive slides. I think we've talked about all of this. This is some of the team's work that suggests that people who start at lower creatinine clearance more likely to have declines in creatinine clearance to below 60, which is our threshold for use of TDF-based PrEP at all. IPREX-OLE, and this is some of Monica's work, really showed age association, people over the age of 50 having an increased rate of declines in creatinine clearance. And, here's this really gorgeous work that Monica was part of, that shows the dose response association for how many doses per week you need to be taking to be associated with these declines in creatinine clearance. And I always struggle with this tremendously, because what you want to say is use the least amount of drug that's effective, but we know the more drug you use, the more effective it is. And so the messaging becomes incredibly complicated, because if you say to someone, get 4 doses a week in to minimize your toxicity, then if they start having trouble adhering to that instruction, then you start falling into tenuous grounds. And so I struggle with it, and I agree we need other options and better options. I do want to remind people that, for a while we said we've never seen a case of Fanconi syndrome outside of people living with HIV using a tenofovir-based product. Not true anymore. There've been a number of case reports. There's this one from a demonstration project here in LA. And then there were a handful of cases also in the Discover trial. So let's not forget that it does happen. And TAF is not entirely benign, as Monica said. This is the Discover trial, randomized people to FTAF or FTDF, followed them, and these were the primary results showing non-inferiority of TAF FTC compared to TDF FTC. And I think we have to remember, as all our panelists have pointed out, this is for exposures that are non-vaginal. That's really critical. We're obviously looking forward to ongoing trials that are going to expand our understanding of the use of this product for vaginal exposures, but we don't have those data yet. So premature. And here are these ultra-sensitive urine markers that suggested favorable, very sensitive lab markers that are favorable for FTAF compared to FTDF. And this is that cross-study comparison that I mentioned that's always so hazardous, where in IPER-GAY there wasn't a difference in creatinine clearance changes compared to placebo, whereas we did see that in the daily dosing studies. Okay, let's move on to the next case, because I don't want to get us behind. So let's see, we have this one called Broken Dreams, and I'm sorry if there's a clicking noise. Apparently my earbuds are hitting a button on my shirt. I'll try and make that stop so I don't annoy you all and you all don't begin to have seizure activity. So this is a 35-year-old man who reports having receptive anal sex with 2 to 3 different partners each month, and he's eager to start PrEP. He was diagnosed with early osteoporosis in 2015, and he has a history of non-traumatic fractures. So what do you tell him? We could proceed with daily oral TDF FTC alone. He can initiate PrEP with TAF FTC. He could proceed with daily oral TDF FTC, but supplement with vitamin D and calcium, or something else. So let's have people vote.
Apologies, everyone. It seems there's a technical difficulty with the polling on Zoom. We will try to launch it shortly. Okay.
Stephanie, with your blessing, maybe what we'll do is we'll just sort of go through what the panel thinks while people are having the opportunity to vote, and then move on. Is that cool?
I think that sounds like a wonderful plan.
Awesome. Okay. So let's go to Connie first on this one. Connie, you have someone with non-traumatic fractures and osteopenia. Would you approach this differently?
Well, in this case, I was, I think I would, again, it's unusual, 35-year-old with non-traumatic fractures. I would want to know if he has osteoporosis. So I guess it would be starting with doing a bone densitometry to evaluate that, because that's pretty unusual in a male, even if he's a smoker. And then this, I guess there's the prudent thing to do, assuming that he is at risk for having osteoporosis, would be to think about FTAF and vitamin D and calcium. So I guess it would all fall under something else, a combination of those.
Great. I think really good point about documentation of what the bone pathology is using a DEXA. Monica, what would you do?
I'm actually pretty panicked about something like a non-traumatic fracture in someone this young, and I really would almost not want even TAF. So even as we were speaking about that, certainly TAF has these bone biomarker improvements, the renal improvements, but it doesn't mean that TAF isn't bone and renally toxic. In something this extreme, I would truly want to veer away from tenofovir. And so we have filed for approval. We actually have the dose, sorry, as a treatment approved, and we can talk to the company and see if there's a possibility while we're waiting for approval of the IM Cabotegravir every 8 weeks, if we can get it for this patient. That's how worried I am about something as crazy as a young person having a fracture.
Yeah, thanks, Monica. I think that's a really good point, and I will tell you that there is a compassionate use program for Cabotegravir while it's awaiting approval. You can the entry mechanism is online, and you can do it. So that's not completely off the table, even waiting for regulatory approvals. Alison, how are you approaching this? Would you do something different? What do you think about, someone who might actually even, assuming you wanted to do a tenofovir-based product, even, depending on sort of a decisional balance conversation with someone while awaiting a compassionate use, something availability based on their risk, do you try and get them to take calcium and vitamin D in addition to a daily pill, or what do you do?
Yeah, so I would agree with Monica in the sense that I am worried. A 35-year-old with non-traumatic disorder, I'd be worried about some genetic condition or something else, me putting them at risk. But I also don't want to have the delay, because we certainly have seen the step down from people who come in to get PrEP to actually get that PrEP prescription. So I would be alarmed to wait for, I'm not sure how long that is. So I would lean towards doing the TAF FTC with a quick desire or a wish to get him to the compassionate release, but would not want to leave large gaps of time, because we certainly have seen people seroconvert while you're waiting to get people started.
If I can just add one more thing. I know that we are in the realm of creative ideas, but PEP, the idea that you use something else entirely while you're waiting. And I know there's this data-free zone, but 2-drug post-exposure prophylaxis, or sort of a constant 2-drug regimen, dolutegravir 3-TC, something, dolutegravir or pivirine. I wonder if anyone would think outside the box there.
Yeah, Monica, I think it's an interesting question. Again, data-free zone there, right? And I'm going to guess that, there would be sort of a level of uncomfortability with doing something for which we have no data. But it is really important, I think, to do no harm and think outside of the box. I think the context would really need to be shared decision-making with a patient about what their ongoing longitudinal risk is, because you were obviously not going to serve anybody well if this person acquires HIV as we're trying to figure out what's the best thing for them, versus short-term benefit of some sort of bridging strategy as we work towards getting something that is going to be safer. But I think it's always good to push the envelope and think, what would we and the patient be comfortable with? Mm-hmm. So I think that's really great discussion, and I see there are some questions coming in the chat that we can zip back to. Just to remind people that the bone mineral density loss that's associated with TDF FTC-based PrEP can be about 1% per year, but that it is reversible in older populations 6 months after coming off TDF FTC, but not so much with youth. And that's important to remember, that young people who are accruing bone mineral density and bone mass, which happens up to about age 25, my adolescent colleagues tell me, Dr. Agwu, we need to be really careful about potentially having long-term implications for skeletal development, and not rebounding with stopping of TDF-based PrEP. These are the findings. Whoops, I seem to be zipping through slides too fast here. Again, in sort of almost dose response comparison data from IPREX, people who didn't get exposed to TDF-FTC, people who were supposed to be taking TDF-FTC, and people who were adherent to TDF-FTC having spine and hip effects on DEXA that were very profound. And this is the 6-month recovery data of, again, older individuals coming off of TDF FTC-based PrEP and resuming their baseline trajectory thereafter. There are some data, both from the HIV treatment literature, that you might expect calcium and vitamin D to mitigate some of the bone mineral density loss. But again, as Connie and Monica both said, somebody who's starting from this questionable point of having non-traumatic fractures, you're probably not going to be really buoyed by that observation, and ability to take additional pills is going to be something that's going to be really challenging for somebody who may already be struggling to take a daily prevention pill. And there are some anecdotal data from the PrEP literature, again from the USC site, that suggested that vitamin D supplementation was salutary for bone turnover markers in MSM who were taking TDF FTC-based PrEP. These aren't clinical data, but they are a little bit reassuring. Not sure how relevant they are in the era where we have TAF as an option. So this is the 24 and 48 and 96-week data from the Discover study. Again, FTAF shown in blue here, and FTDF shown in crimson. The DEXA Z-score changes at spine and hip over time. And Monica, just back to your point where, we said, TAF isn't benign. Absolutely true. These do, short-term 96-week data suggest increases in Z-score at these relevant points. Again, I think Connie's point is you'd want to know where you're starting from to decide if you're even comfortable leveraging TAF FTC in these sorts of situations. This is one of my favorite graphics and trying to figure out, how to have conversations with patients about TAF FTC and TDF FTC. I know there's some people who are wholesaling, switching all of their MSM and trans women to TAF FTC. I'm not convinced that we're there yet. Julia Marcus created this infographic. It's on Twitter. It's publicly available. And I think it's really helpful in going through with patients to think about what the differences are, what populations we have data for, and these sort of little talked about important differences that we haven't touched on yet of, these decreases in LDL cholesterol that you see with TDF-based PrEP, increases on a small scale with TAF-based PrEP, and the weight gain that you see with TAF-based PrEP that you don't see with TDF-based PrEP. And I have to say, every time I've had, all other things being equal, obviously this is outside of the context of the fractures or the renal dysfunction situation, this conversation with people, unless pill size is an overwhelming consideration, I've had very few people sort of be interested because of this weight gain and the LDL issues. Have you all had sort of the same sort of response from people, all other things being equal?
I don't, at least in my experience, it hasn't played out as a major factor. I think what in the realm of information that's being distributed, people are focusing, at least what I hear is more, they hear that it may be beneficial for their kidneys or their bones, but it doesn't seem like weight gain and LDL has gathered a lot of currency, at least in terms of what people are accessing online.
I do think, though, that this ID Week abstract, a couple of days ago with this question of weight loss with TDF, and we're really struggling with, is it weight loss with TDF and efavirenz or weight gain with instis and TAF? But there is this question that TDF is just less associated with weight gain, and I am seeing it coming into play in discussions in San Francisco, at least, of people being concerned about the TAF and that weight gain question.
Yeah,
mean,
Alison, how about you? Yeah.
yeah, I mean, not so much. I think what I have heard, and the Baltimore market has been flooded with these lawyer commercials about the harms of Truvada, and so people are starting to pick that up. And when you mention that, are talking about that. So, have not heard so much about the weight loss, weight gain issue, but it's that, are you putting on the harmful thing? And I think important as we think about legacy in some places about medical mistrust, et cetera. That's one thing that we've had to navigate.
Yeah, here in LA, we've had a lot of concern about that potential weight gain issue, and it really does color people's perceptions. Interestingly, what I've sort of noticed is with some adolescents and young adults, the pill size issue does loom really large. Some people really do struggle with the TDF pill size, and that can be a really important differentiator of people being able to adhere versus not. So I think that's sometimes minimized as a potential concern, particularly for youth.
Yep, agreed.
Okay, so let's move on. So case number 3, a kiss is a terrible thing to waste. Now, anybody who can name what Broadway musical that line is from gets extra bonus points. You can put it in the chat. It's actually a little bit of a trick question because the musical actually never opened on Broadway. It closed out of town before getting to Broadway, but that's okay. So 28-year-old cisgender woman is referred for PrEP. She was also diagnosed with obesity, hypertension, and sleep apnea, and she had a gastric bypass 6 months ago. Since the surgery, she insists on eating clean and takes several vitamin supplements in support of the vitamin wasting that happens after bypass surgery, including vitamin A, B3, B6, E, ginkgo biloba, and milk thistle. So she is interested in starting PrEP, and the question is, how do you instruct her to optimally implement PrEP? Do we use daily oral TDF-FTC, a double dose of daily oral TDF-FTC on demand, TAF-FTC, or something else? We'll have people vote. And no, it's not the Rocky Horror Picture Show. Rocky Horror, always a good answer to anything that's sort of offbeat like that, did actually open on Broadway. It was at the Circle in the Square. Mike Sag, you such a scene stealer. He probably Googled it. Okay, so it seems like most people, about 70% of people, are saying just go with straight up TDF-FTC. So, Monica, let's start with you on this one. What would you do for this person? I'm going to predict what you're going to say. You're going to say, I keep coming back to Cabotegravir.
I do. Well, actually, okay, couple points. So 3 and 4, on-demand and daily oral TAF-FTC are not approved for vaginal sex. And in this, they just haven't been studied, which is a profound disappointment for those in the field. And daily oral TAF-FTC is now being studied in a phase 4 study in cisgender women, but we don't have the data yet. So it actually only has to be 1 or 2 or 5, and then double dose. I don't see the point of that unless there's a question about malabsorption with the gastric bypass, but I think it should be okay. And so daily oral TDF-FTC is the only thing that's approved. But yeah, something else I think is of interest. And the Cabotegravir, when we talk about it later, we should remember that obesity and increased BMIs are a risk factor for those who failed Cabotegravir, and so I'm positive that we'll talk about something to do with pharmacokinetics. I feel like you're trying to lead us along with Cabotegravir.
I do seem to be leading people in that direction, don't I? I have no agenda here. So just to remind people, and I'm sorry, Connie and Alison, did you have anything you wanted to add to that before we sort of jump into this a little more?
I'm just excited that she's looking to get her groove back. And so I think as much as we can do to support her, that is great.
Yes, exactly. You haven't told us, is she still, what is her BMI? Is she still large after her?
No, she has a normal BMI now.
Okay. I would go with daily because I feel like I think you're going to tell us more about absorption issues, but I think there's very little data in this space. So I would be comfortable with a normal BMI of using daily dosing of TDF-FTC.
Yeah, thanks, Connie. I agree with you, and that is sort of where I went. This actually was a real patient that I saw, and so the question came up, with these sort of micronutrient dumping, what do we know about malabsorption of oral PrEP or oral antivirals in general in these sorts of situations? And just to remind people that this gastric sleeve that we're talking about is depicted on the right side of this slide. It's really excising a portion of the stomach to create a much smaller sort of neo stomach out of the original stomach compartment. So the sense of satiety happens with a much smaller food volume. That's sort of how it works. And that's very different from on the left, which is a gastric bypass, where the stomach is bypassed entirely, and the sort of duodenum and jejunum are sort of reattached to the proximal portion of the stomach. So we're talking about the situation on the right of this slide. And so when you do look into it, again, I apologize for the non-people first language in the title of this slide, but there's limited data on TDF-based pharmacokinetics. These are people living with HIV after sleeve gastrectomy. And the bottom line is there was a decrease in some of the pharmacokinetic parameters up to 6 months after the surgery, but by 12 months after the surgery, the pharmacokinetics had returned to pre-operative levels. So I think that it's this first year after a surgery that we would need to be concerned about. There's some limited data about this double use of tenofovir-based preparations in treatment-experienced people living with HIV. Again, apologize for the non-people first language on the title of this slide. And there was one case, so 10%, small numbers, of the people getting Fanconi syndrome. So I think particularly with pharmacokinetics returning to baseline values fairly quickly after surgery, double dosing is probably not something we want to do. So I agree, assuming that there weren't parenterally administered options, single dose daily TDF-based PrEP is probably what we want to do there. Not a lot of data, but again, you have to make good decisions absent good data. And that's what we did with this participant, and she's done quite well. And knock wood, has remained HIV uninfected. Monica, you have a question? I saw you.
Yes, I would just say that Dr. Cullum's, demonstration projects really, to me, gave me comfort that the 7 doses a week is at least as measured by tenofovir diphosphate levels in their studies, at 3HP, and I'm sure Connie, you could talk more about it, it gave me comfort that we may not need that 7 doses perfect a week for protection from HIV infection in women, which had been modeled and touted so often. So the demonstration projects really, really helped me.
Connie, did you want to make any other comments about that?
Yeah, I think, thanks, Monica, for bringing that up. We've done several demonstration projects in South Africa, Kenya, and Zimbabwe, where we have evidence that based on drug levels that women were probably taking an average of 4 doses a week, and HIV incidence was still much lower than we would have predicted in a counterfactual. So I kind of think this idea that got perpetuated from some of the initial PrEP efficacy trials that women, there's a higher bar for the adherence and efficacy, and slope is steeper for women, may be not as true as we thought. They may get substantial benefit from less daily dosing. So I think that's good to know that I think we sometimes fuss about the wrong things when we have incomplete data.
So even if the absorption's a little down.
Yeah, so yeah, we may be on the higher end of the curve than we need to be with daily dosing.
Thanks, Connie. I think that's really important to remember, that our understanding of these correlates of protection and how to advise people about dosing is still really in evolution, even here, 10 years on, coming up on after the FDA approvals in the US, right?
And I think, just to make one last comment, there is an ongoing study by a colleague of mine, Dr. Kenneth Mugwanya, which is going to try to do the benchmarking of daily dosing in women, so we can back extrapolate in the way that the iprexolate data allowed us for MSM. So we will have more data on that relationship of adherence and efficacy from stored samples.
Super exciting. Thanks, Connie. Okay, so I'm running a little behind because this has been such an exciting discussion. So let's go to case 4. It's a dangerous world out there. We have a 55-year-old transgender woman who comes regularly for PrEP follow-up, and all indications suggest she's adherent to PrEP. She has 4 to 5 male sexual partners per month, and her condom use is a little inconsistent. She has a history of recurrent rectal chlamydia with interim documentation of clearance with appropriate treatment. You confirm the dates and the treatment provided. And so what do you tell her? So here are your options. If she has one more STI, you're going to stop her PrEP. And, some of you may be scandalized at that statement, but we'll come back to that. This is an occupational hazard of condomless sex, something that I find is never helpful to say to anyone. America, grow up, use a condom. We'll come back to that as well. Daily doxycycline with her TDF, FTC. Doxycycline post-coitally up to 3 doses per week, or have her partners gargle with Listerine before oral sex or oral anal contact. So why don't you guys vote? And while you're at it, I will tell you, Whistle Down the Wind is not a terrible musical. And I will argue that vociferously. Michael will talk offline. Oh, Christopher said it was terrible. Sorry. It has at least one good song. Okay. All right. So happily, everybody, or more than half of people, like this idea of doxycycline post-coitally. We have 30% who like doxy PrEP, which Connie can tell us more about in just a minute. And, I just want to say that, harm reduction and meeting people where they are with their use of condoms is so critical to this sexual health conversation that, I've heard so many patients come in with stories of providers who say, if you have one more STI, I'm not giving you PrEP anymore. And that's, in my opinion, that's absolutely 180 degrees the opposite of what we should be telling people. Ongoing bacterial STIs are an opportunity to interrupt that STI transmission cycle, to educate people about why condoms are still useful. But at least we are being incredibly successful with the use of PrEP at preventing HIV transmission. And the last thing we should do is stop their PrEP. It is an opportunity to continue to have ongoing conversations about sexual health and sexual pleasure and what we can do to support people. So I think that's really important. This actually is a real billboard that was up in West Hollywood, California, which is, near where I live, around the time of PrEP US FDA approval. You thought I was joking. I wasn't. This was real. You can see on that billboard who promoted it, and we'll just leave that right there. But Connie, do you want to talk a little bit about doxy PrEP and how you're studying it?
Yeah. So there's been a lot of interest in whether we could use doxycycline to prevent bacterial STIs, particularly syphilis, gonorrhea, and chlamydia, although the expectation is a lot of gonorrhea is already resistant to tetracycline, so there may not be a benefit there. And this interest was actually led to a clinical trial as a sub-study of Iprogay, which showed when they offered men up to 3 times a week dosing of doxycycline, that they were in this slide, it's summarized here. So it was about 230 MSM in Paris and France who were in the Iprogay study, and they showed that they could reduce chlamydia and incident chlamydia and syphilis by about 70%, no impact on gonorrhea. And it was provocative, but really it hasn't been adopted as policy in many places because people wanted to know, this was in the context of 2-1-1 dosing of PrEP. Would people be able to use event-driven doxy with daily PrEP, which is often used in the US? And they also wanted more information on resistance. So with Dr. Annie Lupmeyer at UCSF, where I'm co-leading a study with her to look at doxy-PEP in both HIV-infected MSM and transgender women, as well as HIV-negative MSM and transgender women on PrEP, and we're about halfway enrolled, and we'll have more data in the next couple of years. So I think it's a promising idea, but really I think we'd like to know that it works in other populations and try to really understand whether there's any harm, significant harm in terms of resistance. So if I were in San Francisco or Seattle, I would say this is a perfect person to refer to the study. Daily doxy is being studied in a much smaller study in British Columbia, and I think they're just getting started, so we may not have data on daily doxy dosing, but I would be worried about potential GI side effects with both TDF, FTC, and doxy on a daily basis, as opposed to post-exposure basis.
Connie, can I ask you, we have a lot of experience with these doxycycline and related compounds, minocycline, in the treatment of acne in the dermatology literature. And, it seems fairly benign in that context. What's your gut about what we're going to find about the safety and microbiome about this in this context?
Well, I think safety should be very high. I think we're going to look at that. We are looking at that, but so far have no real concerns. And the main safety issues are really, if you don't take it with water, you can get a pretty impressive esophageal ulcer if it gets stuck in your esophagus. Rare though. And then the increased photosensitivity, which is not a big issue in Seattle, but maybe more in other parts of the country.
Climate change, it'll be an issue soon.
And then the microbiome, there's such, really we don't use doxycycline or tetracycline for many treatment of many infectious diseases, so we're not expecting that we're going to do that much harm, but we will look. There's if you do look at the studies that have looked in the microbiome, there's high prevalence of tetracycline resistance already in adults. And so whether or not we're going to increase that, we'll look, and we'll also look at tetracycline gene expression. So not just shifts in the microbiome, but are we really causing any shift in terms of increased expression of these resistance genes? And we're not expecting to find that will really impact the resistance in gonorrhea, which is highly resistant to tetracycline in a substantial minority already. And there's really been no evidence of chlamydia or syphilis acquiring resistance to tetracycline, but we're looking at that as well.
Great. Thanks, Connie. So, Alison, I have a question for you. We're a minute or two over into the question and answer period. We do have 10 minutes for Q&A. We have one more case. Can we take 3 minutes and jump into that case? Is that okay with you?
Yeah, let's be muy rápido because we do have a fair number of questions coming in chat.
Not a problem. Okay, so mouthwash actually does reduce colonization with GC, just FYI. That wasn't crazy. Okay, shot through the heart and you're to blame. Hopefully that one's transparent. 24-year-old man, severe trigeminal neuralgia syndrome provoked by TDF-FTC PrEP on 2 occasions, immediately after initial dosing and on re-challenge a month later. This is a real case. Identical syndrome upon immediate dosing with TAF-FTC. Extensive neurologic workup, otherwise negative. 7 male sexual partners in the last month. Engages in oral and insertive anal sex. Does not use condoms. What do you do? Re-challenge him with daily oral TDF-FTC with a multivitamin. Re-challenge him with TAF-FTC using vitamin B6 alone. Give him Cab-LA and Rilpivirine-LA for treatment. Split it apart and use the Cab-LA part for prevention. Compassionate use Cab-LA I have a headache. Stop asking me questions. And we're going to be muy rapido per Alison. I expected a whistle down the wind tune. IAS-USA team. Okay, so compassionate use, 75% of people said this is actually a real case. So I will tell you that's exactly what we did. We got compassionate use for this individual, and he's doing great on it. Just in case people are wondering, this is actually a real thing. There are these neurologic syndromes. They're fairly rare, but there are case reports in the literature, including one from Partners Prep. It wasn't a trigeminal neuralgia, but it was sort of an upper extremity syndrome. So these things do happen. They're rare. There seem to be mitochondrial dysfunction. So keep that in mind. But, you know, where this has sort of all been pointing to, and Monica's been waiting 50 minutes for me to get here, is, of course, Cabotegravir, the HPTN 083 study and our sister 084 study looked at long-acting injectable Cabotegravir, gluteal injection, 600 milligrams every 2 months. The primary results showed initially we thought a 66% reduction in HIV incidence favoring the Cabotegravir participants, and then in a final analysis dealt with some post hoc data, a 68% reduction in HIV incidence and Cabotegravir incidence compared to TDF-FTC. And my reading on this is that this is an effectiveness result. What this means is an injectable PrEP, a long-acting product, covered sex acts better than a daily intervention in these relatively young, high-risk individuals with fairly chaotic lives. And I think we're still trying to figure out correlates of protection, onset. Do you need an oral lead-in? Can you use non-gluteal sites for injection? And, the biggest bugaboo, I think, of long-acting PrEP in general, and we'll see this, I think, with future agents, is it obfuscates diagnosis of breakthrough infections. Conventional testing algorithms seem to be delayed, and that includes nucleic acid testing. So we are piloting viral load testing as part of the open label extension that's ongoing now in an attempt to avoid integrase class resistance in Cabotegravir breakthroughs, which we did see in some of our breakthroughs that would compromise integrase-based first-line treatment. So really important to tease out. Let me stop there because I want to make sure we have at least 5 minutes for questions. And I want to thank our incredible panelists for this great discussion. And I'll turn it over to Alison to moderate some questions.
Fantastic. So we have, how long do we have? There are some really good questions that have come through. So we'll just talk until we get the hook to stop talking. There are a few clarification questions, Rafi, and group Connie and Monica. So maybe we'll chime in. First, there was one, when you talk about, just to clarify, if women don't need 7 days of PrEP, how do you tell them to take it every other day, et cetera? I think it's worthwhile maybe tweaking that a little bit, make sure people understand.
Thanks. Well, we still counsel people to try to take it every day. I do not promote every other day dosing. I really think we don't know that. But I think what I was trying to say is that, and I think some of the data coming out of our demonstration projects suggests that people are better about adherence when they're at risk. And so I think what we really need to tell people is that they should aim for daily dosing, that what's most important is that it doesn't work instantly and that it may take up to a week to get levels. And so if they can predict when they're at risk, that they should make sure they're on it and try to take it daily. But I do not endorse event-driven dosing because I don't think we have enough information.
I agree. And then patients often ask about 211. People really anxiously want to know when this will be an approved option in the U.S.
Honestly, I will be shocked if it ever gets regulatory approval. I don't think there's motivation for an updated NDA application. So I don't think we're going to see it. I think the updated CDC clinical guidelines that have been out for public comment and are expected to be out final are going to include 2-1-1 dosing. You know, the WHO guidance already includes it. The IAS-USA guidance has been including it since 2018. So I think guidance are out there for people who are enthusiastic about it. San Francisco has been a leader in including it in their guidelines for PrEP for even, I think, the longest at this point. So I think we're there. We just sort of have to all get on board.
And then I think a really important question, updates on PrEP drug interactions with hormonal therapy for the transgender population. I think really critical question to make sure we clarify.
Yeah, great question. And, you know, studies are ongoing, but the lion's share of the data continues to reinforce that bidirectionally, there are not clinically significant interactions with cross-sex hormones. There was a little bit of a question as to whether tenofovir levels with TDF and some feminizing hormones, usually in the context of spironolactone use, also decreased tenofovir concentrations by about 30%. That's not been replicated in all studies, nor is it thought to be clinically significant. But very importantly, the cross-sex hormone levels themselves do not appear to be affected by TDF use. And there are some ongoing data that have recently been presented in transgender youth as well, looking at both transmasculine and transfeminine populations, really looking granularly at those questions for youth in particular as well. We're awaiting those data for Cabotegravir. We don't expect there to be interactions, but we're working on those analyses now. In the phase 2 study, there didn't appear to be a clinically significant interaction with contraception hormones, but of course, that's not asking exactly the same question, but we agree, critical data.
Well, there are several other questions that Raphael and others can please try to answer in the chat. There's one that I just want to make sure I take so everybody hears it. The question was, would you consider holding PrEP, FTAF or TDF when a high-risk patient was less than 25 years old? The answer is absolutely not. Absolutely not. So they are eligible for PrEP all the way down to 35 kilos, would not withhold that. We were just talking about some nuances. So absolutely no, you proceed. And the rest will take offline. Thank you so much, everybody. Raphael, Connie, Monica, always a pleasure. Fantastic job. And thank you for all the questions and engagement from the audience.
Thanks, everyone.
Thank you.
Now I'm going to be joined by my illustrious co-chairs. I think it's time for us to close it out.